everyone. Here is the hematology lecture. There is a lot of information, a lot of important information in our hematology unit. A lot of labs, which are very important for us to know what the blood's made up of, and then some disorders of the blood. All right. So in hematology, what we need to do um, is we need to figure out what the cell does. We'll go through each one of them, the red blood cell, the white blood cell, the types of white blood cells, platelets, all of that. So it's not just a one tiny little part, it's the whole thing. Um, every system is linked into the hematology system. So what does basically the hematology, the blood, it transports oxygen, nutrients, cellular waste products. Um, it regulates our body temperature, the pH, and the fluid balance. And then it transports the cells that protect the body, the white blood cells. It kind of keeps everything moving. So in the notes here, it says, bottom line, if the hematology system is not working, there's something wrong in that system, the patient is going to be sick. Once we get to the disorders, the disease processes, you need to know what differentiates each disease process from the other. For example, there's several types of anemias, and you need to know the different types. This covers the hematology system. Um, it's not just the blood cells, it's the bone marrow, it's the blood and the blood components. So red blood cells, white blood cells, there's different types of white blood cells, the platelets, the vascular system. Um, the disease processes, there's different disease processes when the red blood cells are affected. There's different disease process when the platelets are affected. And there's different disease process when the white blood cells are affected. So like in a platelet, with the platelets, we're going to be looking at clotting disorders, DIC, you guys have probably heard that a little bit. With the red blood cells, the anemias, there's different types, like I said. We're going to go through each type. And then white blood cells is the most commonly like leukemias. So there is a lot in this. So I encourage you guys to listen to the lecture over and over. I know my voice gets kind of boring, but there's a lot of good information that you guys will need to know. Heme is a very important unit, and it's very lengthy. So overview of the hematology system. An adult has anywhere between 4 and 6 liters of blood. Anywhere from 46 to 63% of that is plasma. So the rest of it are the things like we've talked about. The white blood cells are leukocytes. The red blood cells are the erythrocytes. The platelets are the thrombocytes. These elements are all formed in the red bone marrow, like we talked about, I think, in musculoskeletal, in the flat and the irregular bones. We'll get into the rest, those other two comments once we get further down. One thing Pam does have here in the notes is when we are working with our patients and we see their labs come back, maybe their white blood cells are a little bit elevated, or maybe there's looking like they might have like a slight case of anemia. I can't stress this enough for every system. Treat the patient, not the machine or the number. You have to make sure, and I don't know if it was this class that I said it in a lecture before, but um, if your patient is asymptomatic, that's just a number. Um, I don't know how many times I've been told that by the doctor. I can go to a doctor and say, "Hey, this is what's going on with the patient," and they'll ask you, "Well, what's the patient looking like?" But so always make sure you are treating the patient, not the numbers when it comes back from their lab. We only treat patients that are symptomatic. So that's why we as nurses need to know what the symptoms are. So if we are taking care of a patient on the floor and we have, a lab come back, what should we have a lab come back and it's off, we need to know what symptoms they might be having based on that lab. All right, so moving on. Plasma is a majority of water, only 91%. And it's just basically the transportation vehicle, transportation, whatever, for all of those other elements that are in the blood. Proteins that are the plasma proteins are things like the clotting factors, the albumin, and the globulins. So in the plasma, these clotting factors, prothrombin and fibrinogen, I think they're clotting factors number 1 and 2, they're synthesized, made in the liver, and then circulate in the plasma until there's an issue like a clot. And once the body recognizes that clot, they'll be activated and actually get to work. Albumin is also made in the liver. It maintains like a blood volume, blood pressure, by pulling the tissue into the venous system and, vice versa. One thing I learned with my niece being pregnant, when her albumin dropped so low, she actually started having lower extremity edema. My brain went straight to preeclampsia because she's had all these other things going on with her, and I was like hyper vigilant about what was going on. I didn't even think that, hey, her albumin is low, so it cannot hang on to all that fluid, so it's just being put out into her tissues. But the albumin that's circulating will keep that fluid in the vascular system where it needs to be. And then also the plasma kind of helps with the body temperature regulation. If somebody's getting really warm, they're running and they're sweating, that's why the heart pumps faster. It's getting that fluid to where it needs to go to try and get the body cooled off. You've heard of people getting plasma, or if they're getting blood transfusion, they might be just getting the plasma portion of it. Um, we see this when, like, say somebody's been in a motor vehicle accident and they're on warfarin. Whatever, we need to make sure that they have the clotting disorders, or the clotting, sorry, the clotting factors. So if they are in Coumadin and obviously they can't have surgery right away, they'll be given plasma to try and get the prothrombin, the fibrinogen, the clotting factors in, so that they can't, or so that they don't bleed to death. I've got to pause this here for a minute. All right, I'm back. Sorry about that. So moving on to red blood cells. Red blood cells are the little disc-shaped red cells that go through the blood. They carry oxygen um, that's actually bonded to the iron and hemoglobin, so that they can carry the oxygen to all the other cells of the body. This is how our oxygen, when we breathe it in, circulates throughout the entire body. Red blood cells stay in the bone marrow where they mature, and then um, when they're ready, they'll be released into the blood system. things like a lack of iron in the diet, low hemoglobin levels, low red blood cells actually are what cause anemia, which we'll get into later. But some of the signs and symptoms of anemia are shortness of breath and weakness, which is because there is a lack of red blood cells, a lack of hemoglobin. So when we did the respiratory unit, remember when we discussed that when somebody's oxygen saturation is low, it's actually going to stimulate the kidneys to release erythropoietin or produce more erythropoietin, which actually stimulates the bone marrow to produce more red blood cells. Um, when there's more red blood cells, there's more ability for them to carry more oxygen throughout the body. So it's kind of everything's all tied together. I don't know how much I can stress that in this course. Um, our body needs protein and iron in um, in our diet so that we can make hemoglobin to make more red blood cells. So it's another thing where we get into the anemias. We'll get into that when we get there. Um, but without protein and iron, we're going to run into problems with anemia. Folic acid and B12 are also parts of anemia. They're both needed for um, the DNA synthesis of stem cells in the red bone or the red bone marrow. Um, so if we consider the ingestion or taking in or eating vitamin B12, that's called an extrinsic source. Um, the red blood cell lifespan is about 120 days. Once this 120 days is up, the heme portion of the red blood cell actually converts to bilirubin, the liver excretes it, and they're eliminated in the feces. If this process is accelerated up and there's more red blood cells being converted to bilirubin um, and excreting them through the feces, this is where we're going to see jaundice. Um, red blood cells, the um, normal level for a male is about 4.71 to 5.17. And for a female, it's 4.2 to 4.87. When we see higher levels of red blood cells, we're going to think chronic hypoxia. When we see lower levels, we're going to think anemia or possibly blood loss. So, like I said, it is directly connected to when those oxygen saturations drop, especially if we're in our COPD patients, um, where they're used to sitting down at like 85% O2 saturation, we're going to see the higher red blood cells. Platelets, normal ranges of platelets are 150 to 400,000. It's a very large range because the body can function in between that range. And there's so many things that can throw it off. Generally, we don't see disease till about 70,000 or lower. Um, Platelets are formed in the red bone marrow and stored in the spleen. We'll get into the spleen in a little bit, but there's so many things that all the blood cells are formed in the red bone marrow. So for platelets, their function is basically hemostasis. It causes vascular spasms, it causes platelet plugs, it causes chemical clotting and vasoconstriction of an injured blood vessel. So platelets are the big thing we need when there's an injury or a cut to cause that blood clotting so that people aren't bleeding out. Basically what they do is they clump inform these clots or plugs in the blood vessels. Like if you're cut and you cut through a blood vessel, which is why you bleed, um, the platelets will come to the rescue, clump up right there, and cause a blood clot so that the person isn't losing any more blood. Platelets are also colorless. They don't have a color. Um, the different platelet factors or chemicals needed for clotting are prothrombinase, thrombin, and fibrin. I don't think we're going to get into the big whole stages, but the big thing is each stage has a different or a different task that they do to stop the bleeding. Um, so signs and symptoms. I've got my notes all over the place on this. Signs and symptoms of low platelets would be any type of, if the person's bruising easy, maybe they've got petechiae, which is that it's basically superficial bleeding into the skin, and it looks like a pinpoint rash with reddish purple spots. Generally, we see this most often on the lower extremities. You're gonna see things like bleeding gums, fatigue. Women are gonna have heavy menses because they're not gonna have the clotting, and they're gonna bleed a lot. So any type of like unusual bleeding. So maybe somebody gets a very small cut and it just continues to bleed and bleed and bleed and ooze and it doesn't clot up. We think low platelet levels. Um, we might see urine in their blood, or in their urine in their blood, blood in their urine or in their stool, just because if they're really pushing to have a bowel movement, um, or maybe just a little bit of trauma in the urinary system. Um, if we see a platelet level less than 10,000, we might actually just see internal bleeding. There may not be an injury, they just may be bleeding internally. Um, and then also if they have an enlarged spleen. The enlarged spleen is because there's too many platelets that build up in the spleen, and so the spleen gets bigger and tries to work harder. So that is one reason that there's an enlarged spleen with the platelets. Another reason they might have thrombocytopenia, which is just a fancy word for decreased platelets. Um, they might actually have a inability to produce the platelets. Hold on one second. Sorry, my daughter's still up. Okay, I'm back. Sorry about that. It is. I honestly try and record in the middle of the night so that I don't have interruptions. And it's literally my youngest one dog and one cat down here, and I cannot get to anything. All right. So, reasons that somebody might have thrombocytopenia, like I said, is the platelets are becoming trapped in the spleen, and it actually causes the spleen to grow. They might have a decreased ability to produce platelets. Things like leukemia, anemias, viral infections like HIV, chemotherapy, and actually excessive alcohol intake will all affect the platelet production. And then the third reason is that the platelets are being broken down faster than the body can produce them. So more are being broken and destroyed than produced. Might be an autoimmune disorder that's destroying the platelets. Might be medications, infections. Yeah. So our biggest priority with people with thrombocytopenia is we need to make sure we are not that they're not getting injured. Can be a trauma, can be a fall, can be even shaving with a razor, no contact sports, even using aspirin and ibuprofen cautiously because that will affect the platelets as well. Other things that we don't want to do as a nurse, we don't want to if at all possible, we do not want to give them any IM injections. And there's such a risk for perforating the rectum um, that we also don't want to do any rectal temps. So I think that covers pretty much everything with platelets. Um, oh, newborns, when they're born, they have very low levels of platelets and low levels of clotting factors. So that's the reason why we give them vitamin K when they're born. It's just to kind of help them stimulate all this and get their platelet levels up and going in case they do have an injury. All right, moving on to the lymphatic system. Um, the lymph system, basically what it does is it filters out pathogens, toxins um, from the tissue or the fluid. Um, there's lymph vessels, there's lymph nodes and nodules. The spleen is part of the lymph system, and the thymus is part of the lymph system. So the nodes basically are where the pathogens are filtered out to be destroyed, and the lymph vessels are what return the clean lymph to the blood. So you guys have all heard the term lymphedema. What is this? Have you guys, I know um, sometimes the CNAs actually do lymphedema wraps or lymphedema treatments. It's basically exactly what it sounds like. There's lymph fluid that's building up, and it appears as edema. Um, there's massage that can be done to try and get some of this lymph fluid back into where it needs to be. There's wraps, all sorts of different things. If too much lymph fluid is taken out of the blood, it can actually affect the blood pressure. So these people that have the terrible lymphedema, they 9 times out of 10 are going to have a low blood pressure. We kind of went over this. Nodules are like small masses um, where there's an opening to the environment, whether it's a respiratory, urinary system, reproductive, digestive system. So an example of a lymph nodule is the tonsils. When they are filtering out too much gunk, too many toxins, too much whatever, this is when the tonsils become inflamed. So that's why you get tonsillitis, is because it's been filtering all this lymph fluid, and it's got too much bacteria, too much pathogens, too much toxins in it, and affects the actual lymph node nodule. Um, the lymphocytes and macrophages are part of the lymph system, um, and they actually like the lymphocytes. We'll get into this when we get to the white blood cells, but they identify the abnormal cells, and then the macrophages eat it up. They phagocytose them, and then yeah, we'll get into that a little bit later. All right, lymph nodes, nodules. They are more common in areas of the cervical, the axillary, and the inguinal areas. So the spleen is actually considered a non-vital organ. It's useful, but it is not needed. Um, the body will compensate. If it has to be removed due to a trauma or something, a splenectomy, the body will make up for it. It is the largest organ in the lymph system, and its functions are to remove cellular waste, maintain that fluid balance. They're taking stuff out, but they don't want to take too much out. They make and activate white blood cells for the immune system. Removes the older, abnormal, damaged blood cells, takes all the damaged ones out. Can actually store the red blood cells, the white blood cells, and the platelets. Um, So when the spleen actually detects like bacterias um, and or viruses, it actually produces lymphocytes to go and fight off infections. So bacteria enter the body becomes infected. The spleen's going to actually produce more lymphocytes to go to that place of where there's an infection and to take care of it. If the spleen is removed because of what the function of the spleen is, that person is going to be at a higher risk for bacterial infections because that spleen helps fight off the infections. Once it's gone, there's not that level of defense. The thymus is just a little tiny gland, um, and it sits right behind the breastbone. What it does is T lymphocytes live there, and they mature there, um, and those are what fight the infections. So the thymus is actually kind of a weird little gland. It is present at birth and it grows till about puberty. And then once a person hits puberty, it starts to atrophy, and sometimes it is basically non existent. But it has all these um, matured T lymphocytes that continue fighting and build up antibodies. So it's not always present, but it's what it does is always present for the rest of a person's life, if that makes sense. Here's just a picture um, of where the spleen sits. All right. Moving on to some of these tests. I think the next few tests are basically um, just coagulation or clotting tests. Then we'll get into a couple red blood cells, then white blood cells. I do want you guys to know your labs. Um, like I said at the beginning of the lecture, these are the numbers, but always treat your patient, not just the number. So PT or prothrombin time, INR, International Normalized Ratio, or PTT, partial thromboplastin time, are all tests that are used to determine the how thick the blood is, how thin the blood is. They all depend on um, what's going on, if a person's on warfarin, heparin, whatever. They all have their specific things that they look at. Somebody might be, I think I have on an anticoagulant, things like AFib, or maybe they've got a history of DVTs or PEs. Maybe they have artificial heart valves. A lot of times that I've worked with PTs, INRs, PTTs, are when patients are just having a hip or a knee replacement. They're going to be on Coumadin for quite a while. Um, reason being that some of these people are, like especially the hips and the knees, they're used to being up, going, but once they have surgery, their life slows way down and they're not moving like they normally do. So that makes them at a huge risk for clots. So that's why they're on the heparin, the Coumadin, what have you. D-dimer is here in the notes as well. It's kind of out of place, but I do want to talk about that. A D-dimer, I believe, I can't remember the number. I want to say it's less than 500 is okay, but I don't think that's appropriate. 220 maybe. I think it's 220. Anyways, if it comes back elevated or positive, that is positive for a blood clot somewhere in the body. It does not tell you exactly where, so you'll have to do a little bit of investigating, whether they're doing CTs or MRIs, trying to find that blood clot. But a positive D dimer does tell us that there is a blood clot somewhere in the body. Um, yeah. So Moving on to talk about each test individually, the PT, or the prothrombin time, um, measures how many seconds it takes the blood to clot. So that's where this 9.5 to 11.3 seconds comes in. That is a normal person who is not on any type of blood thinner. However, um, somebody who is on warfarin, we want to see that 1.5 to 2 times the normal of 9.5 to 11.3. Because when they're on a blood thinner, we want to make sure that their blood is thinner than average. PT is used for warfarin or Coumadin, whatever one you want to call it. What it does is it measures clotting factors for 1, 2, 5, 7, and 10. Um, remember we talked about fibrinogen and prothrombin. Those are the clotting factors with the platelets. This is what it measures. Um, anytime there's issues with these clotting factors, 1, 2, 5, 7, and 10, um, that PT is going to be a lot longer. Now, if they don't have anything that we want their blood to be thinner for, then we don't want it 2 times the normal. Just kind of depends on what they have going. We also might see a elevated or a prolonged PT when somebody has liver disease or issues with their liver because it's not able to make that prothrombin. So, INR, International Normalized Ratio. Now you're going to see a PT and an INR run at the same time. They're generally done together because they're both used for Coumadin. Um, so they used to just do the PT. Now they added the PT INR, or the INR to the PTR. Ugh, the INR to the PT. I can't talk. Um, generally, INR is done, like I said, with the warfarin. I'm not sure exactly. Should be used once client has been stabilized. I'm not exactly sure what that means in here. And it really depends on where their INR is sitting, what their Coumadin dose is, of how often they're having their INR checked. Sometimes it's every week, sometimes it's every other day, sometimes it's daily. um, normal range is about 1.3 and below, I believe. Um, this therapeutic range is when somebody is on Coumadin. We want it higher. We want their blood thinner. Um, so generally we want it anywhere between 2 and 3. And it just kind of depends on what disease process, what surgery the patient has had, what the doctor's preferences are. Um, but we want it at least above 2. Like I said, things that somebody might be on Coumadin and have their INR checked is if they have a fib or a history of heart attacks, history of a DVT, history of a PE, or even an active DVT or PE, and if they've had artificial heart valves placed. Another one that I don't have listed in my notes here is if they've had a CABG, um, the coronary artery bypass graft. A lot of people are on Coumadin or blood thinners after that. Partial thromboplastin time. Um, this is more for um, like a heparin therapy to see where the heparin has these folks at. Pam has 30 to 45 seconds. I know a lab book says 50 to 70 seconds. So we just kind of go by what our lab, when we're working out in the field, what our lab says. We want this 1.5 to 2 times the normal when they're on heparin um, to make sure that their blood is thinner. They might be on a heparin drip, or they might be on heparin injections. Just kind of depends. Um, they do have Lovenox, and I know a lot of my students that I've had at Brookwood give Lovenox every day. But if they're allergic to heparin, they are able to be given Lovenox. So if a PTT is long, or yeah, long PTT would be like unexplained bleeding or easy bruising. That's why we would do it. But diagnosis might be the DIC, um, liver disease, or it might also be done before surgery just to see where their blood is sitting at. Again, if their PTT is short, it might be the DIC because it clots and it hemorrhage. It's kind of a DIC is both too much clotting and too much bleeding. And then a short PT might also indicate advanced cancer, not liver, anything when the liver's involved, but other types of cancer. Um, Reason being is that the coagulation factors are produced in the liver. So, all right, moving on to red blood cells. These are called red blood cell indices. I can't say that word. So I gotta kind of look. My notes are all screwed up here. When a person has their hemoglobin drawn and it's low, and we start looking at them for anemia, these labs are what we're going to look at to determine what type of anemia they have. So the MCV, if you remember the V, is for volume. It tells us the volume or the average size of the red blood cell, a single red blood cell. Generally, it's 82 to 90. But the sizes that they look at, they're normocytic, macrocytic, which means large, and microcytic, which means small. The MCHC tells us the color to help determine what type of anemia. Basically, it's the concentration of hemoglobin on that red blood cell. Could be normocytic, which is normal color, hypochromic, which is pale. The MCH is the weight of the hemoglobin per single red blood cell. So basically, how much hemoglobin is in each red blood cell. Weight, or the range, is generally 26 to 34. And an increased MCH or an increased weight indicates macrocytic anemia, so large cell anemia. Lower weight will tell us that it's a microcytic anemia, a lower weight anemia, small cell. When we get into iron deficiency anemia, it's going to be a low MCV, so a low volume, and a low MCHC, so a low color, a hypochromic color. Vitamin B12, you're going to see an increased MCV, which is increased volume, and a normal MCHC, so a normal color. RDW actually looks at the width, or like if it's abnormal, it's not round, it's not spherical, it doesn't look like a disc, um, of each red blood cell. An example of this is sickle cell anemia. Now I know these don't make sense, but we will get into anemias once we get there. So if you guys have any questions on these, please get a hold of me. All right, white blood cells. So white blood cells usually ran with you'll hear white blood cell differential. It has the different types of white blood cells ran in it. So a normal white count is anywhere between 4,500 and 10,500. We don't get too far in depth in the white cells here. I do have several, probably 5 slides on them. But when we do the immune system next week, we'll get more into it and explain more of what each does. So there's neutrophils, eosinophils, basophils, lymphocytes, and monocytes. Neutrophils, these have the most generally in the circulation. They respond the quickest, and it's generally anywhere between 55 and 70% of the total white count. Neutrophils are the body's first line of defense. So, if bacteria enter the body, neutrophils are going to be the first little soldiers out there to fight against those infections, those bacterial infections. When the bacteria enters the body, these neutrophils move right into the affected area, engulf that bacteria, and eat it up. So, generally, the mature or the segmented neutrophils are released first, and if that body continues with the infection, the body's actually going to release the immature neutrophils, because they aren't producing them fast enough for the body to fight off the infection. But when these immature neutrophils are released, they're called bands. So it will be noted in the differential if the bands are present. So if there are bands in your labs, this means the infection is getting worse. The bacterial infection is getting worse. You're going to hear this called a left shift or a shift to the left. But just remember, bands mean that the bacterial infection is getting worse. Another term I want you guys to know is neutropenia, especially when we are working with like chemo patients or even on like med onc at Gunderson. I don't do clinicals at Mayo. I don't know what floors they actually have. But when we're working with cancer patients or chemo patients, their neutrophils can actually be pretty well wiped out. So one thing I do want you to know, if somebody's neutropenic, these are the patients that we have to protect in any way possible from bacteria. And so we actually have to protect them from, they might actually be on a neutropenic diet or reverse isolations to make sure that we're not introducing any type of bacteria or bugs to them because their body can't fight it off because they don't have the neutrophils. So like we may gown up and do like we're going into a room that's on contact precautions, but it's only protect the patient from us. It's not protecting us like because the patient has a disease. It's the opposite. It's called reverse isolation. The neutropenic diet actually tries to restrict a patient from getting any type of food that might have some sort of bacteria in it. These are things like obviously like rare meat, undercooked eggs. Generally, they say they can't have eggs unless they're hard boiled, just because even if they have a runny eyeball egg, where the yolk is soft, we call them runny eyeball eggs. But it's things like in cookie dough. Maybe somebody's making cookies and they can't eat the cookie dough because it's got the raw eggs in it. Any type of unpasteurized beverages like fruit juice or milk. They can't have any fruits that can't be peeled, like strawberries. Raw veggies they can't have, deli meats, yogurt, and like things like takeout or fast food because they don't know exactly what's in them. So they have to be very careful not to ingest anything that could actually give them an infection because they have no way to fight it off. Basophils, these actually are the smallest amount, the fewest number. They can be present with like allergic reactions, um, but they actually increase when the body is healing chronic infections and inflammatory process like an allergy. Eosinophils, um, they're there to fight parasites um, and respond to allergens like a bee. So if somebody gets stung by a bee, they're allergic to it, the eosinophils are the ones that are going to be there fighting. Monocytes, these are the second line of defense after the neutrophils um, against bacterial infections, foreign substances. So the neutrophils will respond right away because they're the first soldiers out there. Monocytes there are um, the second ones out there. So the neutrophils come, do their job, and they're basically for the acute phase. The monocytes show up later in the acute phase once the neutrophils are getting tired out, and then they work for like chronic infections. So if somebody has a chronic UTI with the catheter, they're going to have increased monocytes. These also actually rise with viral diseases. So chronic infections and viral diseases will increase the monocytes. Lymphocytes, they also increase with chronic or viral infections. Um, they are different types. There's B cells, T cells, and NK cells, which are called um, natural killer cells. Um, yeah. So I think that is it for labs. I just make sure to for the different types of labs. I am going to take a potty break and pause this, and I will be right back in just a few minutes. All right, moving on to disorders of red blood cells. This is where we're going to get into all the different types of anemias. And yes, I do want you guys to know um, the different types of anemias. So there's different types of anemias. There's when there's impaired production of the red blood cells, there's destruction of the red blood cells, or there's chronic or massive blood loss. Could be a GI bleed, surgery, trauma, whatever. Um, but we'll get into that. I don't want to spend all the time on this. You guys can look at the notes on this one that tells you. Um, we kind of went over it. The indices of the red blood cells. So like if there's a normal MCV, MCH, and MCHC, um, you're gonna see that more in like an acute blood loss or sickle cell anemia. But you guys can look over those parts on your own and make your own tables. So anemia, it is always a symptom or condition caused by another problem. You don't just have anemia. You have something that causes anemia. So, like I said, it might be um, dietary, where they're not taking in enough iron, folic acid, or vitamin B12. Might be hemolysis, where those red blood cells are being destroyed or lysed. I don't know. Um, just depending on what's causing it. Might be at birth, there might be a toxin that they're exposed to. And then there's some other causes like thalassemia. Um, basically, those red blood cells are, their structure is impaired. Um, don't want to get too far into it, but people with thalassemia actually need frequent blood transfusions, and generally their life expectancy isn't very long. Signs and symptoms of anemias in general. Um, they're going to be pale. they're going to be tachycardic because their body's trying to get more oxygen to the tissues, so their heart's working harder. Same with reason they're going to be tachypneic. They might be irritable, fatigued, and shortness of breath because they don't have that oxygen floating around like they normally would. Um, there's low hemoglobin levels, low red blood cell counts. So the body's fighting to try and compensate for those. Um, I want you guys to, once we get into the different types, I want you guys to know the symptoms of each. So, like example, vitamin B12 deficiency anemia. These people are going to have numbness in their hands or their feet because B12 is needed for that neurological function. Pernicious anemia might have a beefy red tongue, um, or iron deficiency anemia. Sorry, I had my note wrong. Iron deficiency anemia might have glossitis, like a beefy red tongue. They might have the spoon-shaped fingernails, the clubbing of their fingernails, because they have the lower oxygen saturations, and that's what causes that. And they might also have fissures in the corner of their mouth. But we'll get into each one of them now. So, iron deficiency anemia. This is the most common. It's because um, there's not enough iron in the blood, so there's not enough red blood cells. The red blood cells that are there might be smaller, um, and they're not as healthy. So um, it's caused by not taking in enough iron. Might be excessive blood loss in like a trauma or a surgery, um, lack of stomach acid. Um, Iron deficiency anemias is called a microcytic anemia. Remember, micro, so the red blood cells are small, they're unhealthy, um, and there's not as many of them. Most time, the biggest risk groups are females because of their period. A lot of people get anemic because of their period. Young children are also iron deficient anemics. Interventions is we need to teach them to try or educate them on the importance of eating things like red meat. Um, Red meat's very important because it's very high in iron. Um, Dark green leafy vegetables, dried fruits have a high iron level. Enriched whole grains have a higher level. Um, they can be taking supplements, um, can just be taking iron pills. We do encourage them to take vitamin C with their iron because that will help the body absorb the iron and get it into their system. Um, these supplements, especially for kids with the liquid forms, actually do stain the teeth, and it can actually stain them red. Um, so we need to find a way that we're not, um, so that they're not getting the iron straight on their teeth. To make sure that the treatment is working, the supplements, the lab test, all of that is going to be needed to be taken several months to make sure that everything is getting built up to where it needs to be, and that it's staying there, and that the levels are getting back the storage, the amount of stored red blood cells are building up as well. All right. I don't know what I did. All right. So that is iron deficiency anemia. Iron deficiency, not enough iron in the diet. Um, Most common in children and females of childbearing age. Interventions increase the iron in their diet, whether it's in supplements or food. Red meat, dark leafy vegetables are the biggest things. Um, yeah, supplements can be staining to the teeth. So B12 um, deficiency anemia is a macrocytic anemia. These people are not taking in enough B12 or folic acid. Um, Folic acid actually helps in forming um, of DNA and heme, the iron part of a hemoglobin. Um, and it also, when people are pregnant, they take folic acid so that there isn't fetal neural tube defects. Again, things that contain folic acid is kind of like the same thing with iron. It's the like liver or red meats, the green leafy vegetables, legumes. I can't say that word. And the grain products all have folic acid in it. Sometimes these people are taking in enough folic acid or vitamin B12, but it's not being um, absorbed in the body like it should be. So maybe they've got some sort of GI issue going on. B12 is needed for making red blood cells. Um, Another name for B12 anemia is pernicious anemia. We'll get into that in the next slide. Um, but B12 is also needed for to keep that myelin. If the gets into our neuro chapter, but um, on our nerves there's a thing called a myelin sheath, and things like multiple sclerosis, the myelin sheath is destroyed, and that what makes it they're not able to um, get their nerve impulses and do, like, if I say I want to move my arm, maybe my arm might be jerking, um, or not even be able to move at all. So that myelin is like the fattery covering on the nerves. So when my brain tells my hand to move, it has to follow all the nerve things. We'll get into it in neuro, but it has to follow like a hot dog chain. Um, so um, when they're deficient in B12, that myelin covering um, can be destroyed, and that's why we get the numbness and the tingling in the extremities. That's why we get nerve damage when it comes to not having enough B12 in our bodies. B12 is also um, required for an intrinsic factor to transport transport the vitamin B12 to the ileum to be absorbed. So, yeah, there's a lot of things there. Sources of B12 um, are things like meat and fish and I can't, shellfish, poultry, and milk. Um, like I said, I didn't go into that too much, the intrinsic factor, but the intrinsic factor is needed to help the body absorb the B12. I feel like I'm kind of going all over the place with this. Um, but when that body doesn't have the intrinsic factor, it doesn't absorb the B12. So the B12 might be there, but without the intrinsic factor, it's not absorbing it. So therefore, um, they're deficient. um, Pernicious anemia, um, it says B2, but it's supposed to be B12. It's also B12 deficiency. Um, Pernicious anemia is an autoimmune response. So the immune system is basically attacking themselves, and it's not recognizing normal cells. It's seeing them as abnormal and fighting against them. So these antibodies are actually destroying the gastric um, parietal cells, which decreases that intrinsic factor. So the body is not absorbing the B12 in the small intestines. So pernicious anemia is an autoimmune response that destroys those gastric parietal cells, decreasing the intrinsic factor, which decreases the absorption of B12. This is where that glossitis comes in with that red beefy tongue. So that's kind of like the big um, determining factor of whether it's pernicious anemia or not. and that is the B12 anemias. Aplastic anemia, that bone marrow that makes the red blood cells becomes fatty and it can't make red blood cells anymore. Generally, it can be caused by a congenital defect, maybe exposure to toxins. Chemotherapy can also cause somebody to become or to have aplastic anemia. Um, Also called hypoplastic. Basically, um, in hypoplastic, there's cells there, but they're not enough to keep life going. Aplastic is no cells. Hypoplastic is there's not enough there. um, Pancytopenia. This just means this is a vocab word I want you guys to know. Um, there's decreased numbers of red blood cells, platelets, and white blood cells. Um, can be fatal when a body doesn't have all of these. So overview: person is on chemotherapy. It actually turns that bone marrow fatty. The bone marrow is no longer capable of producing the amount of red blood cells. There's not enough to sustain life. So these people are going to be pancytopenic, which means um, they're not going to have enough neutrophils to fight off infections. They're going to have thrombocytopenia, the platelets, um, and they're going to be decreased red blood cells. Um, People that have aplastic anemia are sometimes prescribed something called epigen, however you want to say it, just because this will help the body like be stimulated to produce those red blood cells on its own, um, rather than doing blood transfusions all the time. The epigen will help the body realize that it needs to make more. Ah, I don't know why my slides are messed up. I think I'm missing one. Yes, I am. I'm missing this one. Anyways, yeah, we kind of went over this in the last slide. The pancytopenia, red blood cells, platelets, white blood cells are all decreased. Um, there we go. Signs and symptoms of aplastic anemia. It's the same symptoms as um, regular anemias until it's further into the disease progression. So you're going to see that tachycardia, which will eventually go into heart failure. You're going to see petechiae because the platelet levels are low. Remember, that's the superficial bleeding underneath the skin that looks like pinpoint purple rash. Um, you're going to see high infection rates because they don't have the white blood cells or the neutrophils to fight off that infection. And so these people actually pass away or die because of infections. They might become septic, or actually might bleed to death because they don't have the white blood cells, the platelets, um, and the red blood cells to function properly. Generally, the first diagnostic would be to do a CBC, but it will eventually progress to a bone marrow biopsy. So when they do the bone marrow biopsy, it's actually called a dry tap. So when they go in, try to pull out the bone marrow, it's going to be pale, fatty, yellow, instead of the red, healthy bone marrow that comes out for somebody who is healthy. Um, a lot of times they cannot determine what the cause of this is. Um, Generally, it's so far advanced and they can't go back and fix what damage has already been done. So if that bone marrow is already turned to basically fat, pale, yellow tissue, they cannot turn it back into red bone marrow. So um, the biggest way to fix it is a bone marrow transplant. Sometimes they can be put on steroids, um, but steroids also come with knocking out the immune system, so they kind of have to weigh the benefits versus um, the risks. So um, if it's an autoimmune cause, they're going to trying to suppress that immune system, but then again, you have to worry about um, infections. So, all right, moving on to sickle cell anemia. Sickle cell, as you can see in this picture here, they're not the round, healthy, circular, disc-shaped red blood cells um, that red blood cells should be. They're sickle-shaped and they can clump and catch up and cause clump together. So anytime there is a decrease in oxygen levels, um, these disc shapes or spherical shapes, red blood cells will turn into this crescent or sickle shape um, cell. It's very easy to be broken. Um, and a lot of times that I'm trying to look at my notes here. Um, the spleen and the liver might actually be enlarged because when they're trying to filter out and get rid of the abnormal um, cells, these cells are going to build up the spleen and the liver and actually clog up, basically. A lot of times you're going to see jaundice in these people um, just because those bilirubins are elevated. What else? What else? What else? These sickle cell or crescent-shaped red blood cells. Generally, the red blood cell life is 120 days. With these, it's only 10 to 20. So they they become very anemic because the blood cells are dying so quickly, but they're also not healthy. So it's kind of gets them from both directions. So, like I said, um, lifespan is 10 to 20 days. Um, both parents need to have sickle cell anemia to pass it on to the child. So, if both parents have it, the child will have sickle cell disease. If one parent has it, that child will have a sickle cell trait. But if they're paired with another person with the sickle cell trait, their child will have sickle cell anemia. So I hope that makes sense. So both parents have to have it in order for the child to have it. It's most common in the African or Eastern Mediterranean um, descent. Um, and with these guys, we are going to give them oxygen because once their oxygen levels return to normal, those red blood cells will actually return to their normal shape. Now, as you can see in this picture here, when the blood cells are round and disc shaped, they fly through the vascular system no problem. But when they become sickle cell, they get caught up in the curves and turns and everything, and actually cause blood clotting in the veins. Sickle cell crisis. This is an acute exacerbation. So it's all of a sudden those cells are severely sickled. Um, it causes congestion in the vascular system. The cells are clumping and clotting. that blood becomes sluggish and is not flowing very easily. Now, if you think about it, if somebody becomes dehydrated and the volume of blood decreases, especially pulling out the fluid of the blood and leaving all these sickle cell cells, you can see where the crisis would occur. Generally, these cells um, will build up in capillaries and veins, in organs, joints, and bones. Um, Triggers are things like pneumonia, where they're getting sick, exposure to extreme cold, extreme hot, infection, diabetes, um, dehydration will trigger it. Um, yeah. Sickle cell anemia is very painful because these sickled cells are clumping up, not allowing the oxygen to flow where it needs to, and it will actually sit in some of the joints. So they'll have swelling in their joints. Um, they're going to have abdominal pain because that spleen and some other organs are going to be actually grow and enlarge because these sickle cells are just sitting there getting caught up where they would normally be excreted or destroyed. They're just sitting there. Um, they're going to be hypoxic and they're going to need oxygen because their fevers are elevated, their pain levels are way through the roof, um, and the lower their oxygen saturation goes, the worse the cells will sickle. Um, they might also have renal failure symptoms because these cells that are normally flying through the vascular system are just clogging up, and they have to go through the kidneys to be filtered, and their kidneys are just becoming clotted or clogged up with the garbage. All right. Um, Another complication with sickle cell anemia is this hand-foot syndrome. So their hands and their fingers and their toes, because all those tiny little bones, those cells are getting caught up in the joints and causing destruction in the bones in the hands and the feet. Generally, the crisis um, might last like 4 to 6 days, but they're going to need to be hospitalized. They're going to be a need to be on oxygen. Um, these people with sickle cell anemia cannot, or it's difficult, I should say. They can, so they need to be active when they're able to, but they can't do things that would lower their oxygen saturation. So like a strenuous activities because they're trying to catch their breath, or things like scuba diving because the their oxygen sat levels might actually drop, and it can actually cause a crisis if they're scuba diving. So we need to educate them on how to prevent crises. Um, if they're having severe pain, we need to treat their pain, obviously. Sometimes they're going to need blood transfusions to actually replace those red blood cells that are so damaged and destroyed. Obviously, like I've said a million times, they're going to need to be on oxygen, even if their oxygen levels are normal. Anytime somebody is in a sickle cell crisis, they need to be on oxygen to try and get those cells to plump back up and be of normal shape. They're going to be in IV fluids because we need to flush those kidneys and get all that stuff that's clogging them up. We need to get that flushed out. They're going to be on antibiotics if there's any possibility of infections, um, and warm compresses to dilate those veins to try and make it easier um, for those abnormally shaped red blood cells to flow through the vascular system. Um, what do we want? What else do we want to know? Um, Sometimes folic acid will help treat these and prevent crises. We need to teach them to drink lots of water. Um, we don't want them to get it dehydrated because that just makes it even more sluggish. Um, but educate them on fluid and drinking lots of fluids. We need to make sure that they're avoiding extreme temperatures, um, extreme hot, extreme cold. Either way can actually cause them to go into crisis. We want to teach them that it's good to exercise, but we don't want them to overexert themselves. So we don't want them running 5 miles um, a day because that can actually send them into a crisis as well. They also think that smoking can actually exacerbate the symptoms because it does decrease the oxygen saturation. So, all right. I need to check my battery. Oh, my battery's good. All right, polycythemia or polycythemia vera. Think about it as thick, sludgy blood. There's too many red blood cells um, that the blood can't circulate correctly. So it's just lots and lots of red blood cells floating around in the vascular system. Um, Polycythemia vera is a primary condition. It's an unknown cause. So the red blood cells, the platelets, and the white blood cells are overproduced in the bone marrow. So then the bone marrow can only hold so much. So once that is saturated and has too many, it's going to spill over and go into um, circulation, and then the organs are going to be filled with the red blood cells. So this blood is really thick. It's going to cause clotting. It's going to cause occlusion of the blood vessels. Secondary causes of polycythemia might be things like a long-term hypoxia from COPD or smoking. So the body, like I said before, when a body is hypoxic, it's going to stimulate the body to make more red blood cells. So when somebody's in COPD and their oxygen levels are 85, that body's going to be telling them to make more red blood cells, more red blood cells. They don't have a shut off switch. So it's telling me that my oxygen level's low, we're going to produce more red blood cells, but it doesn't tell us, oh no, there's too many now, we need to stop. Um, it's basically, it's compensation, but not actually an actual disorder. Where polycythemia vera is an actual disorder, secondary polycythemia is because of the body's compensating. They actually do a thing called a therapeutic phlebotomy, where they're actually taking out blood, taking out the red blood cells, so it's not so thick and sludgy. Used to be called bloodletting, now it's therapeutic phlebotomy. Generally, with polycythemia, we're going to see a hemoglobin greater than 18 and a hematocrit greater than 55%. So, signs and symptoms, chest pain, um, they're going to get short of breath with any exertion. Their um, complexion is going to be dark and flushed, ruddy, because there's so many red blood cells that it's actually causing the person to appear like ruddy, flushed. They're going to have itching because their mast cells are going to be activated, which is a histamine issue. Um, like I said, the causes are because there's so much fluid in the vascular system. There's so much red blood cells. It's basically like they're hypervolemic, they're hyperviscous, and those capillary beds become engorged because there's so much floating through the system. To be diagnosed, they're going to have a CBC um, or even bone marrow aspiration to look and see what that bone marrow is doing. Treatment for this, um, they need to have their blood less viscous. So this is the bloodletting where they're taking out 350 to 500 mLs of blood. So if you think about it, we've got 4 to 6 liters of blood in our system, and you're taking out half. Um, yeah, that's quite a bit actually. Um, they might be put on chemotherapy, um, because chemotherapy knocks out white blood cells and platelets because there's too much. So we're going to use what a side effect of a med to fix something else. We're going to encourage them to drink lots of fluids, to try and dilute the vascular system, all that crud in there. If we put more water in there, it's going to dilute it and make it less thick, less too much. Um, they might be on wearing head hose. Um, if polycythemia is left untreated, these people will die either from a clot or a hemorrhage. So, yeah, we're actually moving along pretty well. How many slides? Oh, we got a lot of slides left. 57. All right, moving on to hemorrhagic disorders. So our first one, you guys may have heard of it. It's hemophilia. Um, these are the people that are missing certain clotting factors. It's a hereditary thing. Um, these people are just they aren't able to clot their blood. Um, they actually form this platelet plug, but it doesn't go into those next stages. Remember when I said I didn't want to get into it? I should have gotten into it, but um, it doesn't progress to a stage 3 where that fibrin um, is built up. There's a little tiny platelet plug, but it doesn't progress to the fibrin. It's genetic. Um, daughters are carriers of it, and sons will have hemophilia. Um, basically, the blood does not clot normally. There's no cure for it. Um, you can treat it by replacing those clotting factors and education. So they need to know their safety, um, things to do with safety. They need to notice bleeding, signs and symptoms of bleeding right away. These people don't bleed faster, and small scratches aren't a big issue. But what happens is they start bleeding into their muscles and in joints, and that's where the issues come. That's where the joint deformities come. Yeah. 80% is classic hemophilia, um, and like 15% is like it's called Christmas disease. Not a very nice Christmas present. Um, like I said, it's not curable. But we basically try and prevent the bleeding into the joints causing deformities, increase their life expectancy and their quality of life. Um, they may be given what's called desmopressin. This stimulates the body to release more clotting factors, um, but it is an inhalation med. Because these people do not form the full stages of clotting, we do not want to give them any IM sub-Q rectal meds because we could actually cause a, when we poke them with the needle, or we're um, doing rectal meds, we might scratch or perforate where they're going to bleed and they're not going to be able to clot. So desmopressin is given as an inhalation med. If a patient has hemophilia and they tell you that they started to bleed, they're bleeding. Always listen to your patient. This is one, I mean, a patient usually knows more than a doctor of what, or a patient knows more of what they're experiencing than a doctor or a nurse can ever tell them. And this is one of the disorders or diseases that you have got to listen to these people. Um, They have experience with this. They know what they're going through. Um, Sometimes the signs and symptoms that they're experiencing are not able to be visualized by us as the nurse or the doctors, but they know what's going on. It can be um, a very bad outcome if we don't listen to them. If they say they're bleeding and we say, well, we don't see any signs and symptoms, that could be they could be disastrous. Um, Things we're going to do is maybe give ice or pressure to sites where they say they're bleeding or where we're seeing signs and symptoms of bleeding, because that will constrict the blood vessels and try and help them slow down their bleeding. We might be giving them blood products to help get those clotting factors. And like I said, we're going to avoid any possible way that we could injure them. I'm not really sure what this slide is, so we're just skipping it. All right, disorders of white blood cells. This is where we are getting into leukemias. So this just shows the bone marrow, the red blood cells, the platelets, the white blood cells, the types of white blood cells. This just kind of shows everything that is produced in the bone marrow. So in leukemia, the red bone marrow actually dumps these immature white blood cells into circulation, called blast cells or lymphoblasts. And since they're immature, they can't fight off infections. So there's a lot of white blood cells running around, but they're not able to do anything. They're not even in training yet. But because there's so many white blood cells, we're going to see less red blood cells and less platelets because there's not room for them. It's going to be, the system is going to be overrun with these immature um, white blood cells. Generally, these people are diagnosed with leukemia when they have an infection um, that isn't responding to antibiotics. So basically, overall, leukemia, we'll get into different types, but overall, um, leukemia is the unregulated proliferation of the white blood cells. Um, they're making them, they're just not mature and they're overabundance. Um, the first case of leukemia was founded in 1845, and it actually means white blood. So there's so many white blood cells that they actually named it white blood. Symptoms we're going to see, obviously, like I said, is increased infections. They're going to be increased bleeding because um, they're going to have lower levels of platelets. They're going to be fatigued, um, maybe even anorexic, anemic, because they don't have as many red blood cells. Here you can see um, the effect that all the immature white blood cells have on the I want to say normal amount of the normal blood. All right, so there is one, two, three, four types of leukemia that I want you guys to know. Um, the first one, acute lymphocytic leukemia, ALL. This is the most common in children. Um, it's the abnormal growth of the lymphoblasts, the white blood cells, the immature white blood cells. Um, this occurs more common in children. Generally, signs and symptoms of this is fever. They're going to be pale. Um, they're going to have weakness, and they're going to complain of bone pain. Um, one of my son's friends, I think he's in um, remission now, but that was his first sign was he complained of hip pain. Went in, I think they treated him for like a pulled muscle or something at first, um, but then they looked more into it, and yeah, he had ALL. Um, the next type is called acute myelogenous leukemia. This is a very poor prognosis. Um, Generally, it affects people over the age of 60. Symptoms of AML maybe like flu-like symptoms. They're going to see weight loss, fatigue, fever, night sweats, loss of appetite. So um, you can see why the prognosis is poor because if my symptoms are flu-like symptoms, weight loss, fatigue, fever, night sweats, loss of appetite, those are pretty generic. So once I finally go in to have that checked out, you can see how far advanced the leukemia would have to be. Chronic lymphocytic leukemia, CLL. This type of leukemia um, is the most common in adults. It affects the B and the T lymphocytes and is actually very fatal. Um, there's going to be an elevated level of those lymphocytes. It's going to be a white blood cell differential will be done, and they'll be able to tell the difference in the white blood cells. And then oh, I think I screwed that up. I did screw that up. No, I didn't. Chronic myelogenous leukemia, CML. Um, Generally, this is found by accident with a high white cell count. Um, but they'll do more testing and find the what's called a Philadelphia chromosome. CML is also fatal. So review those, know the difference of the four. Plasma and lymphatic disorders. All right, we are really moving along. So multiple myeloma, you guys may have heard this, but these are the cancer of plasma cells in the bone marrow. There's a very high mortality rate because it's not generally diagnosed early in the disease process. Um, the cancer's plasma cells in the bone marrow start to reproduce uncontrollably. And if you know anything about cancer, I think we get into a little bit more on cancer next week. Um, but they're reproducing cells, but they're all um, oh gosh, I shouldn't record it, 12:30 at night. Um, they're all deformed, but they'll continue to produce these deformed cells. So these cancer cells are infiltrating the bone tissue all over the body, start to put tumors on all of the bones, and then they begin to um, basically destroy the bones. Um, the bones are going to be weak. They're going to break easy. Um, so we need to teach them how to be safe. Um, we don't want them out going doing contact sports if they got multiple myeloma and having a chance of, breaking bones because their bones look like Swiss cheese. Um, this is another disorder like osteoporosis where there's pathological fractures. So they might break a hip and fall rather than fall and break a hip. Those bones are so destroyed that they just break easy. Um, Once diagnosed, these people generally have a life expectancy of like 3 months. It generally affects men between the ages of 50 and 70. And the number one report for multiple myeloma is bone pain. Because these bones are being destroyed, pain is going to be a huge issue, a huge priority. Um, So that is one of the biggest issues with multiple myeloma. It doesn't matter how much calcium they take in. It doesn't affect the bones. They won't be able to have healthy bones because they drink 6 gallons of milk a day. Um, an emergency issue with multiple myeloma is that because these bones are so fragile and just like Swiss cheese, there's holes in them, there's tumors on them. Um, if their vertebrae break, it can actually cause cord compression. So that is an emergency. They need to go in immediately for surgery. Um, yeah, we don't want them doing anything that could cause an injury. So we need to keep them safe and we need to treat this very painful. You can see here all the dark areas on both pictures are tumors of the bone. All right, Hodgkin's lymphoma starts with one lymph node and it mutates. It goes lymph node chains node by node. So remember lymph nodes, they filter everything. So once it's in one and it'll travel to the next one. Generally, these are started in the cervical or the neck area, and then will go to the other nodes. Because the body is using the lymph nodes to filter out all the crap. Sometimes the crap gets stuck in them and causes cancer in the lymph system. It's lymphoma. Um, For Hodgkin's, the diagnostic or whatever telltale sign, they're going to be positive for these things called Reed-Sternberg cells. Um, Hodgkin's is the most curable type of lymphoma. So the first symptom is going to be swelling in a lymph node. Second symptom, I don't want to say second symptom, but another like, hey, um, is when a person takes a drink of alcohol, even just a sip, they are going to have severe pain because the body's trying to filter it out and it's going to, wherever that affected lymph node is, it's going to be very, very painful. They don't have to drink much. It can just be sips. Um, so, diagnostic is obviously a biopsy. Um, just like any other cancer, 4 stages. Stage 1 is limited to a single node. Um, Stage 4, most serious, least curable, and widely missed. And obviously, radiation and chemo are treatment for Hodgkin's. You can see here where those lymph nodes are extremely, extremely swollen. Non-Hodgkin's lymphoma, um, these are just any lymphomas that are not considered Hodgkin's. There's no Reed-Sternberg cells. There is an abnormality of the B and T cells. Again, there's going to be a biopsy depending on where the affected tissue is. They might do bone scans, um, chemotherapy, radiation, bone marrow or stem cell transplant. Um, I don't know a whole lot of the stem cell transplant, but those things are pretty amazing. My cousin had one down in Panama, I think. Can't remember. Um, he was basically a quadriplegic after a bull riding accident, and he's actually starting to move. It is amazing. Not that he can walk, but he can actually move his extremities now because of the stem cell transplant. All right, sorry, off on my tangent sometimes. Um, Non-Hodgkin's lymphoma, they're going to have those enlarged lymph nodes, but they're painless. They might be things like their tonsils or their adenoids might be enlarged, but it doesn't hurt like Hodgkin's. Like I said, they take a drink of alcohol and they're in severe pain because their body's trying to filter it out. Not with non-Hodgkin's lymphoma. Um, Non-Hodgkin's is more rapid than Hodgkin's. Uh, Generally, the people with non-Hodgkin's have had a previous viral infection like Epstein-Barr, which is the mononucleosis um, virus. They might have had herpes. They might have H. pylori, but they have some sort of viral infection prior to developing non-Hodgkin's. Non-Hodgkin's lymphoma, these people might be put on interferon. It actually increases the immune mononuclear antibodies, and they target and destroy cancer cells. So um, it is a form basically of chemotherapy. All right. And then splenectomy, like I told you before, this is part of the lymph system. Um, the spleen is a very important um, gland and very important organ, but the body can function without it. Um, it can actually be enlarged because there's too many red blood cells that are removed from circulation that are hanging out and stuck in the spleen. Um, any amount of bleeding into the spleen will cause it to be useless. It will not be able to do anything. So even if it's a very small amount, maybe trauma that affects the spleen, they bleed a little bit into it, that spleen is pretty much useless. Um, Once the spleen is removed, that person is at a much higher risk of infection um, because the full immune response is not occurring. The lymph nodes in the liver will take over um, the work of the spleen, but they still um, are a huge risk for infections. Um, what else? If it's enlarged or had blood bled into it, um, when that spleen enlarges it because it's overworking, it can't filter blood the way it's supposed to. It's not pulling the abnormal cells out because it's all clogged up and it can't determine abnormal from normal. Um, I think that is pretty much it on splenectomy. I did want to take a couple minutes. My phone is ringing and it's the middle of the night and I'm not sure who would be calling me. Hold on. Okay, I'm back. I'm just going to put this up so we have something to look at. But what I did want to touch base with you are a few things about blood transfusion reactions. Um, there are different types of reactions. Um, there's the febrile, which is the most common. It's about 2% of people who receive blood transfusions can occur at any time during or after a transfusion, which is why we take vitals before the blood starts at 15 minutes, 30 minutes, whatever the policy may not be. There is a bigger risk if the blood is transfused over 4 hours for these patients to have a febrile um, reaction because that blood sitting out unrefrigerated for 4 hours is a mode for infection. Um, Symptoms of a febrile reaction is their temp is going to go up, chills, headache. Um, with this, we're immediately going to stop the transfusion and notify the doctor. We're going to treat the fever, and it depends on if there's a hemolytic reaction or not. If there is not, if the hemolytic reaction is not suspected, then we might continue the transfusion. Um, urticarial transfusion reaction. These people are going to have hives because there's antigens in the blood. Um, it's just a minor allergic or an immune response. Again, we're going to stop the infusion immediately, notify the doctor, most likely give them Benadryl, and they may end up finishing the transfusion. Hemolytic is the worst, the rarest type of reaction. Um, Hemolytic is actually a deadly um, transfusion reaction. So basically, the um, the two bloods, the patient's blood and the blood that you're infusing, are incompatible, and it causes the destruction of the red blood cells. Generally, this happens within minutes. These people are going to um, appear like they're in shock. So they're going to have back pain, chest pain, chills, fever, shortness of breath, nausea, vomiting. Their blood pressure is going to drop. Um, Treatment for a hemolytic transfusion reaction. Again, stop that transfusion immediately. They need to have normal saline giving. So um, what we're going to do is we're going to pull everything down. We're going to get brand new tubing and a brand new bag of normal saline. And we are going to bolus the normal saline in. We want to keep that vein open so that we can give drugs to basically through the IV route to try and stop them from dying from a hemolytic. So basically, again, we're going to stop it. We're going to give normal saline, new tubing, new everything to try and flush those kidneys because the kidneys are filtering all the damaged red blood cells and they're going to be clogging up. So um, the next one is an anaphylactic transfusion reaction. Um, Generally, they're sensitive to the immune globulins um, from the donor blood. Might be respiratory or cardiovascular in nature. Again, we're going to stop the transfusion. Someone's going to have to stay with that patient because they may code. Um, and it's just the same treatment as if somebody was going into anaphylaxis. Circulatory overload transfusion reaction. Um, there's more fluid than the patient can handle, or the blood was infused way too fast. That's why we generally give furosemide or Lasix in between units to try and get rid of some of the extra fluid, but continue to get all the good stuff from the blood. And that's why we monitor their blood or their lung sounds. So those were the reactions I wanted to go over. Please take notes of those, review them. If you guys have any questions, please let me know on those. As always, if you guys are going through this and have any questions at all, please get a hold of me. Um, I'm going to get this up yet tonight or early tomorrow morning. So again, please contact me if you guys need anything. All right. Good luck and have fun studying.